Welcome to ATARC's webinar series. My name is Jonathan Albaum, and I am the Federal CTO for ServiceNow. And today I have the pleasure of moderating today's panel. I want to begin by welcoming all of our attendees. Today we're going to be addressing the American Rescue Plan. The American Rescue Plan is President Biden's signature achievement in his first few months in office. It aligns with his top priority of providing COVID relief to all Americans. The $1.9 trillion act was passed in March and creates significant requirements for agencies at all levels of government to speed up the U.S. recovery from the economic and health effects of the pandemic. The agencies that are most responsible for implementing the ARP all rely heavily on technology, which really isn't very surprising when you recognize that the president's plan requires all levels of government to be firing on all cylinders to ensure that the $1.9 trillion is used effectively and efficiently in support of the American people. So at ServiceNow, we make government work better for federal employees and the people they serve. And one of the most important ways we do this is by ensuring that public sector can engage with their customers in the best way possible. And we're working across agencies to streamline citizen service delivery. We're working with agencies to manage vaccine distribution and working with a variety of organizations to enable a safe return to offices and to schools. So these are all key elements of the American Rescue Plan. So I'm very interested to hear from our panelists today on how they're supporting these and other aspects of the ARP. So today we're going to have some back and forth between myself and our panelists. We're going to have some poll questions. And I want to also encourage our audience to submit your own questions. At the end of today's presentation, we'll have a chance to go through these. So please send them in. And also remember to answer the poll questions as we get to those, because they will ensure that you get CPE credit for today's session. I want to begin by introducing our panelists, and I want to ask each of them to share a little bit of their background and describe their current role. I'd like to begin with Jonathan Warsh, who is a senior policy advisor at the Department of Health and Human Services, as part of the COVID-19 response team. Jonathan?
Thanks, Jonathan. Good to be with all of you. My name is Jonathan Warsh. I'm, as Jonathan said, a senior policy advisor on the HHS COVID response team. I came to the federal government previously from state government, where I was working on pandemic response in the state of Michigan for the first year or so of the pandemic. And in our current team, we focus on the range of cross-cutting issues that affect HHS. So we're sort of the organizational nerve center for issues that touch CDC, FDA, CMS, other components of HHS, and sort of perform that cross-agency coordination role internally with the White House. So we have been spending an enormous amount of time on the American Rescue Plan and implementing various elements of the spending associated with that plan, and very excited to talk to you about that today.
Thanks, Jonathan. Next, I'd like Josh Corman, who's a chief strategist at the Cybersecurity and Infrastructure Security Agency, to introduce himself.
Hi, I'm Josh Corman. I'm an Emergency CARES Act hiring authority for a 1 year renewable up for 1 year more term as part of the pandemic response that Congress passed last spring. I'm what you get when you put a philosopher in the hacker community for a couple of decades, but I've held roles as chief security officer in the private sector. But I was recruited by Director Krebs last year after the pandemic to be the chief strategist and design and implement CISA's response to the pandemic, both for the protection of healthcare delivery during a once in 100-year pandemic and impact on hospitals amongst adversaries deliberately disrupting and degrading patient care when we need it most, but also in support of the interagency effort known as Operation Warp Speed, so we could develop and distribute first-of-a-kind cures to protect U.S. interests and the public. So I lead a massively multidisciplinary team and bring to bear some experience I drew upon from serving on a congressional task force for healthcare industry cybersecurity for a few years. So we try to put some hacker and executive mindset into the excellent ranks of the federal government over the last year to try to keep things reduce the harm possible, but there was so much harm that we're going to get into that we'll talk about why some of this rescue plan is necessary.
Thanks, Josh. And last but certainly not least, I want Anthony Oroz to introduce himself. And Anthony, I'm sorry if I messed up your last name there.
It's okay. It's Oroz. It's fine. Good afternoon. Good morning, everyone. My name is Anthony Oroz. I'm the Assistant Director for the Pharmaceutical Center of Excellence and Expertise in Customs and Border Protection. I know that's a mouthful, but we've been working very closely, as you know, CBP, where our main duty is facilitation and legal entry of all the goods coming into the United States. So I believe since March of last year, when the pandemic began, we set up a team, CCRT, the Cargo COVID Release Team, response team, to facilitate any pandemic, vaccines, PPE, everything, you name it, into the United States without delay. So started with the PPE back here when that was a big mess, and everybody and their mother was trying to get in some kind of mask or gown into the United States, and that slowed down. And then we had the vaccines. So basically our team facilitates and safely make sure everything related to the pandemic gets into the United States. And we work very closely with the private industry, the drug companies, the PPE producers, to give us a heads up when they're having shipments in. So to this day, I remember working on Thanksgiving night of last year, facilitating the first Pfizer vaccine into the United States, into a free trade zone. So haven't stopped since, and every shipment of vaccine or vaccine material that comes into the United States, we pretty much have our hands on one way or another. So that's pretty much sums up what I do.
Well, thank you, Anthony. You know, one of the common themes across all of your introductions was the vaccinations, and the need to ensure that people could get the vaccines, whether it's them being created, as Josh described, or distributed, that distribution processes that HHS is involved in, that Jonathan talked about, or just getting them into the country, like Anthony talked about. The vaccine is obviously has changed a lot of the game. Still complicated, but obviously it's made a tremendous difference in all of our lives so far. So, Jonathan, maybe we could just jump back to you, and can you talk a little bit about the processes that HHS is involved in relative to American Rescue Plan for vaccine distribution and other activities within the agency? I think I read recently that there was, more than $3 billion of funding sent to state and local governments for vaccine distribution activities.
Yeah, so, if you look at the American Rescue Plan funding, I believe there was about $150 billion that went to HHS. And of that $150 billion, a large amount, 30-40%, was just around vaccine distribution. Some of that money we funneled to community health centers, to pharmacies. Some of it went to FEMA, which was setting up mass vaccination sites. And so, for, I would say, the first quarter of this year, a very large amount of our effort in our funding was just getting the vaccine out and available in as many distribution channels as possible. I think it's, you hear these stories. I think I heard for the NBA Finals that you could get a vaccine at, the stadium where the Bucks were playing, and they were going around and saying, hey, you want to take a bathroom break, go get your vaccine. But in the early days, it's easy to forget that it was not widely available. And it took our state partners, time to figure out how to get distribution channels right. And so that included the healthcare ecosystem. It included, pharmacies. It included local public health offices. And so there was just a really huge amount of our time and effort on the logistics, the operations of getting the vaccine out there, and FEMA played a really large role, especially with a lot of these mass vaccination sites. As a sort of former state official, I would say that the states and local governments deserve a huge amount of the credit for a lot of this work. It took them time to figure out how to get this up and running. But the vast majority of these vaccines are being, distributed and run by local operations. And so I just want to make sure to call that out. there was a bit of a shift, I would say, once supply inflected with demand. And so we, in the last several months, have spent a lot of our ARP dollars and a lot of our time on vaccine outreach and education. And the amount of time it took to get to 50% of the country vaccinated, I believe, is less than the amount of time it took to get from 50% to 70%. And so every incremental, all the incremental progress that we are making now takes time, it takes effort. There's been a lot of, we're sort of in early days of research and understanding on this. I spend a lot of my time now on public health outreach and education. And, I think contrary to a lot of popular opinion, people who are choosing not to get vaccinated now are not monolithic. And so we are sort of really in the early stages of understanding why people don't want to get vaccinated, what might convince them to do so. And so that really has been the shift in HHS's efforts over the last, I would say, 2 to 3 months is much more about vaccine outreach, vaccine education, funding local community organizations, funding faith-based organizations that are doing this work on the ground. And I guess the last thing I'll say about this is we are also planning for a future, but a future that is unknown. We don't know yet whether or not people will need boosters. Our outreach strategy, our delivery strategy, we're building that in real time, but we don't know. I think folks probably saw there's new CDC guidance on masking that's coming out right now. That's another factor. So broad range of activities, but the nature of the work really has shifted as the situation on the ground has shifted with regard to the pandemic.
Thank you, Jonathan. I think, the vaccine distribution in those early days was a tremendous workflow challenge. That it was very confusing, but it was also quite a complicated effort behind the scenes. And, you're right, the state and local governments, really stepped up and played a huge role. And, I think a lot of people have thought about, is there a better way if we have to do this again, instead of replicating this, countless times across all these local governments? But, I haven't heard anybody describe something better. A national approach seems somewhat out of reach at times. So I think your perspective is a really interesting one, having served in the states, in state government, and now from an HHS perspective. I want to turn to Anthony. What are the complexities to make what Jonathan was describing work? How does it work at the border in order to get vaccines into the right hands so they can get to that state health office or county health office? Certainly, it's not simple.
No, in the beginning it wasn't. It certainly got more simple over the past few months. I think we take pride also in working directly with the private industry. That would be the drug companies of Pfizer, Moderna, Johnson & Johnson, AstraZeneca. We always had a personal relationship with these large companies. We know we're in the enforcement business in CBP, obviously, but we know these large legitimate businesses aren't the business of fraud. So we work very closely with them. And they were giving us a heads up on the possible vaccine importations from Belgium and over in Europe long before they ever came into the country. So we were well aware that we were working with them. They had vaccines in the country before it was even approved. So they were in the free trade zone, ready to go, millions of doses. So as soon as that authorization was approved, it got out to the states as quickly as possible. After it gets in the country, we kind of lose it there because CBP, we're a border agency mostly, right? Mm-hmm. But luckily now, that's slowed down quite a bit. Now, the vaccine makers actually, they import vaccine materials almost every day, and we have an eye on that. But a majority of the vaccine now is actually produced in the United States, so CBP doesn't have much involvement with that. Just getting those vaccine materials into the country safely and securely, and make sure they're expedited. They come to different ports every day. We reach out to those ports personally. We have a relationship with over probably 20 ports that these vaccine materials have come in. So they know us, they know the companies now, we have a great relationship. So everything pretty much is seamless at this point. Let's knock on wood on that one, right? Because in the beginning, the PPE was just a complete mess. But things have really settled down. We're kind of in a routine now. And now we're also focusing on counterfeits too. So that's mainly going to be our focus moving forward. I don't think counterfeits they're not a huge issue, as other drugs are right now, because, the vaccine's free, right? So how counterfeiters make any money if they're, if we're giving the vaccine for free at this point, right? So they're not going to make too much money off of that. But, there's always that threat there. In other countries, we have seen counterfeit vaccines where we're having trouble getting the legitimate vaccines. So they haven't made it way over our border yet. And hopefully, like I said, we don't see that anytime soon, but we do keep our eye out for certain things like that.
Thank you. I want to turn to Josh now. And, Josh, you've talked about healthcare impact related to COVID. And, I'm curious your thoughts there. And, also, what was the role that, CISA had relative to Operation Warp Speed and the creation of the vaccine, which you referenced in the beginning, in your opening remarks?
Sure. I guess I'll go in reverse order. We really had two major elements to the CISA support of the federal government and state, local, tribal, territorial. It was the keep hospitals, the national critical function of provide medical care, keep them as open and undisturbed as possible during peak needs to avoid excess deaths, which were numerous, and to provide cybersecurity and physical security support to the cyber assurance level of effort in Operation Warp Speed. So for the designated, funded, granted large organizations that were trying to invent the world's first vaccines for this style of virus, they had significant federal funding and assistance to make sure that we were doing threat intelligence and counterintelligence and marshaling taxpayer-funded resources to keep them safe and running. But one of CISA's tasks as the nation's risk management advisor was to identify the smaller, less obvious, weak links in the supply chain that, if disrupted, could have a profound impact on public safety, human life. So whereas the large pharmaceuticals in the world have very robust global teams for risk management, some of these other organizations that might make a key ingredient in DNA or mRNA, we developed a ball bearings strategy, stealing from World War II doctrine, for these less guarded organizations, some of which had 3 IT people, 0 security people on staff, and would not withstand even the most basic of attacks that could introduce months of delay. After we knew we could invent these successfully and get them through approval, and then scaled production and fill and finish, hopefully not disrupted by ransom attacks and the scourge of ransomware hitting all these organizations, then the last part of that shared responsibility between the federal government, kind of Operation Warp Speed stopped at the distribution points, and then it became state, local, tribal, and territorial. And luckily, CISA's mission to include coordination with SLTT allowed us to maybe bridge that divide a bit for that last 1,500 miles in a lot of cases on ultra cold storage, minus 80 degrees Celsius, to keep cold things cold long enough to get into people's arms. And now we're shifting in that era where the key constraint is really hesitancy. We have plenty of supply, and we have plenty of that we're exporting, but we don't have yet enough people taking this for misinformation, disinformation, and other varied reasons. The net result of both the attacks, let's shift to healthcare though, because this is where I think it's going to take us years to recover. The net result of both the pandemic itself on our limited healthcare institutions and unprecedented levels of cyber attack and this elective sickness from people that aren't taking the available vaccine is really throttling our provide medical care. We saw that when the US in February hit the 500,000 mark of lost Americans to the disease. What was talked about less is the CDC tracks excess deaths, the difference between expected deaths and actual deaths. And on that same day, we had crossed 150,000 non-COVID deaths, with the top demographic being age 25 to 44. Young people were passing away from otherwise treatable conditions, from delayed and degraded patient care, things like heart attacks, things like strokes, things like diabetes, that weren't getting timely care because there was no room in our finite hospital supply chains and hospital institutions. So most of that delay and excess death came from people not wanting to go to the hospital or not being able to get in because of bed count. But towards the fall, some of that delay was exacerbated by record high attacks on hospital institutions from ransom crews. If minutes or hours can be the difference between life and death for heart attacks and strokes, respectively. What do you think 4 weeks did to the state of Vermont with 118 institutions down for a protracted period of time? That would be that would increase mortality during the best of times, absolutely, during a pandemic when we already have so little room. So the long term of this is everyone keeps celebrating in a good way that our mortality rates are going down when people are vaccinated, if they still get sick. But these heavy loads on the national critical functions still put us in the danger zone for those excess deaths from non-COVID related conditions. So it's not merely amount of how many people are dying that we are continuing to be concerned about. It's what is the additional strains and stress on hospitals who have less revenue from no elective surgeries, less hospital staff and doctors and nurses who are retiring early from stress and strain, and less capacity to treat the sick and wounded for long periods of time. It will take easily 5 years to get to full fighting strength again, even once the pandemic's over. So it's not merely that we want people to get vaccinated for fear of mortality. We also want to get people vaccinated to reduce the strain and stress on materially weakened healthcare delivery.
So I think this is a place where, I'd love to hear from Jonathan at an HHS perspective. There's a core part of the HHS mission, which is around recovery, in the ARP recovery.
The way the country operates.